All right, let's start this webinar. I don't know, a few cases, probably like 8 or 10 cases here. Um, so I'm Daniel Vargas. I'm the current president of NASCI, and so welcome to the February 2026 Curious Cases webinar. uh, just so you know, these webinars are meant to be informal and interactive, so please feel free to respond to questions. Feel free to stop me and ask your questions if you have any, and discuss. I'm gonna just show. I don't have any full volume diagram here. Just selected images for each case, and they're most of these cases are very straightforward, really. All right. So this is a 40-year-old woman who shows up asymptomatic. She actually had a history of Turner syndrome, and we did a coronary CTA on her. Uh, Instead, we actually she was getting scanned. She was getting an MRA of the chest, but the magnet where she was in went down, so we decided to move her to CT and scan her with CT. And this was not a coronary CTA. This was just an incidental finding on a thoracic aortic CTA. So obviously, and here's the big arrow sign here. What I'm showing you here is that proximal LAD and distal left main, and you see this bulky um, focus of non-calcified plaque with some positive remodeling of the vessel, but also significantly narrowing the proximal LAD. So a pretty significant stenosis. I think it was more than 70% when we looked at it in cross-sectional imaging. But I'm showing you this for two reasons. One, Turner syndrome is associated with accelerated atherosclerosis, which we can see here. She was only 40. Unlikely for a woman to have this degree of atherosclerosis at that age. Um, and to talk about high risk plaque, so this is a type of plaque that has a couple of high risk features, and these are the high risk features. So we talk about positive remodeling, where the vessel diameter gets wider in the region of the plaque, oftentimes maintaining the size of the lumen. Um, Low attenuation, if we measure the attenuation values at the side of the plaque, at the center of the plaque, less than 30 Hounsfield units would be considered low attenuation. A napkin ring sign, which is an area of higher attenuation surrounding a more low attenuation core, and spotty calcification. All of those are features of high risk plaque. We consider a plaque high risk when we find at least two of these really present um, in that site. So this is another patient just to show you the napkin ring sign, which can be difficult to see, but we have this high attenuation rim surrounding a lower attenuation area. area. So why is high risk plaque important? Um, it's more common MACE in patients with high risk plaque than those without high risk plaque when followed at 2 years. Those that were followed to medium term to lower follow-ups, longer follow-ups, uh, high risk plaque continues to be an independent risk factor for MACE. Uh, and this is interesting. This study showed that um, the more high risk features, the higher your risk of MACE when followed at 2 years. And in fact, these patients presented with MACE at shorter time than those that didn't have high risk plaque. So overall, whenever you see high risk plaque, this patient is at higher risk for MACE and developing MACE at a shorter um, time. I like to show this Kaplan-Meier survival curve where you have multiple lines here. But what I want to show you is so when you don't have high risk plaque and you don't have stenosis, obviously these patients do very well. Uh, when you don't have high risk plaque, but you have stenosis, say you have calcified plaque and stenosis, those patients do a little bit worse. But those patients that have high risk plaque without stenosis do actually worse than the patients that have stenosis only. And if you have both stenosis and high risk plaque, those patients fare the worst of all. So important to know, important to mention that you have high risk plaque on coronary CTA, or comment on the coronary arteries in patients that don't get a coronary CTA like this one. This was a thoracic CTA. Any questions, comments? If not, I'll keep going. Um, this is and I'm showing you only these images first. 31-year-old woman with dilated right ventricle seen on an echo. And you have several findings here. So I'm going to start from the bottom up here. This is a cut through the ventricles, and you can see obviously the RV is dilated. The right atrium is dilated too. You can see parts of the interventricular septum looks intact here. Atrial septum looks intact as well. Same here. There's a slightly higher cut here. We see the pulmonary veins coming in, left inferior and right inferior pulmonary veins coming in. Atrial septum, the higher portion of the septum is intact, and you can see the right ventricle is dilated. When we go a little bit higher than that, we find this abnormal communication. So you have an abnormal communication very high in the atrial septum. Um, and you're seeing here basically the SVC joining the right atrium. And as the SVC comes in, it kind of communicates both with the right atrium and dumps also into the left atrium. Whenever you see this type of um, communication, um, you have to go look for an almost pulmonary venous return. So we talked about the inferior pulmonary veins coming in nicely here. Here's your left superior pulmonary vein coming in, and here's the right superior pulmonary vein draining anomalously into the SVC. So here you have this communication. We're going to see it on a couple of other images here. This is super nice. This is a kind of like a parasagittal view, and I'm showing you the SVC. Here you see a little bit of not shunt, of contrast return into the acigus vein, and the SVC dumping into both atria. Um, and on this coronal view, we see the uh, pulmonary vein, the right superior pulmonary vein, draining into the SVC. So, what is this?
Sinus venosus defect.
Yes. So this is a very nice superior sinus venosus defect with right upper lobe PAPVR. So sinus venosus defects are this defect at basically the level of the SVC as it drains into the atria, and it's 4 to 11% of atrial septal defects. Uh, and the defect is in the common wall between the SVC and the superior pulmonary veins, and almost invariably associated with PAPVR. So whenever you see this type of defect, this type of communication very high in the atrial septum, you have to look for a PAPVR, for a right PAPVR. You're going to find it at 100% of these patients. The opposite is not the true, right? You can have right upper lobe PAPVR without a sinus venosus defect. This acts as a left to right shunt. It's going to lead to pulmonary hypertension, given that overcirculation on the right eventually leads to pulmonary hypertension. All right. Moving on. This is a 62-year-old man, 11-day status post ablation for atrial fibrillation. He showed up with CNS symptoms. I'm going to show you some diffusion weighted images from a brain MR. when you see scatter diffusion um, defects here in the right frontal and parietal lobes. And then we did a CT esophagram. You can see that there's oral contrast and anterior contrast in the esophagus. And this CT did not have IV contrast. And we see here three very, very ominous findings. Um, one, on this one, here's the esophagus. We see a small pocket of air outside of the esophageal lumen, uh, either between the atrium and the esophagus or kind of within the atrium. Hard to tell in this image here. Unfortunately, we also see a small pocket of air in the left ventricular apex and another small bubble of air within the aortic lumen. So what's going on here with that history provided?
Atrioesophageal fistula.
And you'd be correct. So this is a esophageal fistula, which is a very, very bad, dreadful complication of AFib ablation. Luckily, it doesn't happen that often, less than 0.1% of these atrial fib ablation. And one important thing to know is that it happens 1 to 4 weeks after the ablation. It's not immediate. Uh, and the other thing to keep in mind is that the injury is starts in the esophagus. So it's a secondary to a thermal injury of the esophagus, and the injury makes its way back into the atrium once you have that esophageal injury. So it extends into the mediastinum, the pericardium, and then finally the left atrium. The symptoms are going to be very non-specific. Some patients will present with fever, maybe some chest pain, and embolic events like this one here. Unfortunately, this patient, the evolution was terrible. He developed multiple more um, brain embolic events and ended up passing away from these strokes, massive strokes. So not very common. Atrioesophageal fistula, not very common. I don't know how much it helps to have the enteric contrast, but since it is an injury of the esophagus, you might be able to see some leakage of contrast into the mediastinum. Um, and contrary to what people think, doing a contrast enhanced CTA, hoping to see contrast blush out of the atrium, you're probably not gonna see that. Then the injury forms a channel, and you're gonna be connecting the esophagus directly to the atrium. And I think the easier thing to see would be the air um, in the cardiac chambers. Other findings. This case, we also did a contrast enhanced portion, CTA, and it can be helpful because sometimes these patients will have fill-in defects in the posterior wall of the atrium, so they'll form some thrombus or even vegetations in that posterior wall of the atrium. So doing a contrast and non-contrast and contrast enhanced CT might be helpful.
We don't see that much cases, but the two cases I saw, it was a catastrophic, like, and only subtle findings on the CT, just a gas bubble along the atrial wall, and that's it.
Yeah,
I
yeah, and I've seen only a couple of cases in a decade, really, and we've done several CTs looking for it, but they've all been negative, and only a couple have been truly positive. Shaima, you were going to say something else?
no, I agree with you. Yeah.
Cool. This case number 4, 45-year-old man. Um, I was gonna do this everything as a show and tell, but this one I'm gonna see if anyone wants to take it from the audience.
That looks like an Arcapa.
Like a what?
Arcapa?
Can you define R kappa?
Yes, anomalous right coronary artery arising from the pulmonary artery.
Okay, so you're saying the right coronary artery is arising from the pulmonary artery?
Oh, sorry. Wait a minute. No. Never mind. Sorry. Alcapa. It's on the left. The left coronary artery is arising from the main pulmonary artery.
Yes, it is. And so you can see it here. And unfortunately, in these selected slices, I did not put the origin of the right coronary artery. The origin was normal, but you can see here the left main arising from the lateral aspect of the uh, proximal main pulmonary artery. So what's the problem with these patients? How do they present?
They can present with chest pain or shortness of breath, and what it happens is that there can be a kind of a retrograde flow from the um, instead of the flow going towards the heart, it goes back into the pulmonary artery. So usually these patients develop like the mant ischemia that when they start doing some activity, they can develop some chest pain.
Exactly. But I'm going to add a little bit more to this because the vast majority of these patients will be diagnosed in infancy. And they get diagnosed in the first few years of life after presenting with an acute MI. And those that make it into adulthood undiagnosed, like this one, present exactly like you mentioned. So they develop this almost global ischemia, and they'll present with chest pain, heart failure, arrhythmia, etc. And it's all because, as you said, there's going to be a steal phenomenon given the pressure differential. So here's a reformatted image showing all vessels are dilated, not just left main, but you can see that the right coronary artery is tortuous, is markedly dilated as well. So what happens is that people would think, oh, you have the left main coming off of the pulmonary artery, right? And that patient is going to get non-oxygenated blood supplying that myocardium, but that's not what happens. What happens is you're going to have flow from the right coronary artery, communicate via all of these collaterals, and that flow is going to go into the left main, and that retrograde flow is going to dump into the pulmonary artery. So it's going to generate ischemia in all coronary territories as this shunt works its way backwards into the main pulmonary artery. This is not a common anomaly. I've seen a few, I think it's 1 in a million maybe, patients will have one. But occasionally we find them incidentally in patients that present with heart failure later in life. So here's a companion case, and this is even rarer. So this is an R kappa, where you have the right coronary artery coming off of the uh, pulmonary artery. And this was I don't remember her age. She was either late 60s or somewhere in the 70s. So she presented with an R kappa that was diagnosed incidentally, diagnosed actually by one of our residents overnight. But she didn't do anything for this patient. For Al Kappa, they didn't do anything to this patient because of her age. She was not having any symptoms. For Al Kappa, for the other version, this one, they'll do surgery. They'll either reimplant the left main to the aorta, or they do ligate it here and do a bypass, or they'll do a baffle tunnel through the PA. That's called a Takeuchi repair through with a baffle through the PA. All right.
Daniel,
Great.
can I ask a question?
Yeah, go
And
for it.
and you don't have to know the answer. For the Alpha patients who present later in life, like that patient, obviously they would want to do the bypass so they don't have an acute or more MIs, more ischemia and infarcts develop. Do you know if there's like any data on how they do long term, since they probably have a bunch of interstitial fibrosis that develops? And I'm
Yeah,
sure that, right? Like, so their MACE risk overall
it's
is probably
going to be higher.
higher.
Yeah, because and as you said, these patients presenting late, most of them are already presenting with uh, sequela from chronic ischemia or prior MIs. So they're going to be at risk for many already have heart failure to and
Yeah. So they,
arrhythmias, as I said. So yeah, so they
yeah,
probably do worse than the regular, the normal.
right. I'm sure they like watch, I'm 100% sure they watch them like a high
Yeah,
risk heart failure eventual patient,
I
probably.
don't, I don't know if there's any series looking at these on MR and see if there's the degree of fibrosis.
Yeah.
That would be interesting. Yeah, look at an ECV maybe.
Right.
Yeah.
Yeah. An interesting study for someone for a, a junior faculty
What do you do
out there.
about it? I don't. Yeah, I don't know. It would be interesting. Well, the hard thing would be to get a good number of
Like a
cases,
cohort. Yeah.
like a cohort to scan. Yeah. All right. Case number 4. I honestly don't even know what case is coming, so it's going to surprise you guys as much as I'm going to be surprised. 40-year-old woman. Ah, yes. Okay. Um, so I'm going to let someone take it too. If anyone wants to go over it.
The proximal coronary arteries are large-sized, aneurysmal. The LAD and maybe the origin of the RCA is also dilated. So I'm thinking of a process that caused some aneurysms to the coronary arteries, either in such age 40, maybe vasculitis or prior Kawasaki.
Yeah, exactly. So that's exactly that's exactly right. So we have just 3 slices here, and yes, the ostium of that RCA is a little bit wide, right? The left main is markedly dilated and aneurysmal. There's a little bit of atherosclerosis already, early atherosclerosis for a 40-year-old woman, and you can see that the LAD is also dilated and atherosclerotic. So this is not normal, right? You should not have aneurysms in the coronaries at this age. Um, the most common cause of aneurysm in the coronary arteries is atherosclerotic disease, and you'll see aneurysmal vessels in elderly population with just atherosclerosis. But at a younger age, and the second most common cause of aneurysms is vasculitis, and of those, Kawasaki disease is the number one. Here's a reformatted image where you see that um, aneurysm in the left main and aneurysmal LAD. So this was Kawasaki disease. This causes secondary coronary aneurysms. As I said, it's the second most common cause of these coronary aneurysms. It presents as a self-limited vasculitis, medium and small vessel vasculitis, typically in infants and children younger than 6 years of age, and is more prevalent in Asian population. Um, and not every patient that develops Kawasaki disease will develop aneurysms. It's a small percentage of patients that will develop these aneurysms. So inflammatory infiltration in the subendothelial space and smooth muscle cell necrosis, as happens with these vasculitides. Um, and as I said, not every patient will develop aneurysms. In fact, of those untreated, 15 to 25% will go on to develop these aneurysms. These aneurysms can be saccular or fusiform, but typically in the proximal segments and near the bifurcation of these vessels. So left main, proximal LAD, and origin of the first diagonal, proximal circumflex, etc. With any aneurysm, you're gonna lose that laminar flow of the blood. You're gonna start having turbulent flow. That's gonna promote atherosclerosis, thrombus formation, and stenosis. This is another patient with large history of Kawasaki disease with a large aneurysm in the this very long left main, aneurysm of the LAD, aneurysm with thrombus here and the RCA too. Interestingly, small aneurysms resolve as the vasculitis subsides, but a lot of these patients will remain with aneurysms. And I don't do PEDS imaging, but we do see them when we're scanning young adults with prior history of Kawasaki. So we have a pretty large cohort of patients that keep coming to evaluate their aneurysms to make sure that they're not getting thrombosis or stenosis, usually in their early 20s to early 40s. Here's another companion case, another Kawasaki disease, just aneurysmal vessel with areas of calcification too. Of the other vasculitides, involvement of the coronary arteries is not very common. You can see involvement of the coronary arteries in large vessel vasculitis like giant cell and Takayasu arteritis, but not very common. Oftentimes, the involvement of the coronary arteries will be very proximal, and sometimes you see stenosis of the ostium because of involvement of the aortic wall, more so than involvement of the coronary artery. But I've seen a couple of cases of Takayasu's that have actually involved the proximal coronary arteries. This is the only case I've seen of polyarteritis nodosa involved in the coronary arteries. And you have aneurysm and areas stenosis, a little bit of accelerated atherosclerosis too. This also was a younger patient. So don't forget those other vasculitides that can also affect the coronary arteries. Small vessel vasculitis, like granulomatosis with cholangitis, eosinophilic granulomatosis, and microscopic cholangitis. Those won't present with coronary artery disease or aneurysms. So the one to remember is Kawasaki. The other ones are not very common, not in the coronaries. Any questions regarding that one? I just digressed a little bit into vasculitides there.
Beautiful case. I have never seen polyarteritis nodosa.
Yeah, as I said, is the only case I have of this proven PAN. Yeah. But yeah, keep in mind those large vessel vasculitis and occasional rare case like this one. All right. This is a 65-year-old that was admitted with STEMI, ST elevation myocardial infarction, and we did a CTA to assess the heart structurally. And if anyone wants to take this case, that would be great. Anyone want to comment on what we're seeing here? Ignore the aorta. There's an intra-aortic balloon pump in the aorta.
Looks like a VSD near the apex.
Yeah, so we have, so this patient presented with STEMI, right?
Yeah.
So we have a very thin mid to apical septum here, right? There's also thinning of the apex there. And as you go further down towards the base of the mid to apical septum, we see this very large defect here. very large defect. In fact, we see probably contrast from the just going from the left to the right ventricle. So this is okay. Here are a couple of other images on the same patient. Here's that defect in a more um, four-chamber view. This is kind of endoluminal view looking at the septum. That's the size of the defect, 2.4 by 2.7 centimeters on this kind of short axis view where you see that defect in the septum. So some more 3D reformats just to make pretty images. These don't offer much more than that, really. View from the RV of that very big channel there. So this is an ischemic VSD. And this is a catastrophic complication of acute myocardial infarction. Luckily, it is not very common. Only 0.2% of STEMIs will present with an ischemic VSD. And basically what you have here is breakdown of the muscle of the myocardium, and you end up with this communication between both ventricles. It's catastrophic because it leads to acute right heart failure, right? You have all this flow going in from the left ventricle to the RV and overloading that RV. And also with a drop of cardiac output on the left because you're losing a lot of cardiac output and into the RV here. So what do they do with these patients? They were going to try to repair it, but the repair in the acute setting is not going to work. Why? Because this tissue is going to be necrotic edematous. So if they try to patch this, they're going to be tearing the muscle. So what they do is they hope the patient can survive with just medical management for at least a couple of weeks so that the tissue starts scarring down and they can go in and repair it. What do they do? They'll usually do like a Gore-Tex patch or a pericardial patch trying to close that defect. But a lot of these patients are going to do very poorly, and many of these patients won't survive. In fact, without treatment, survival to 1 month is only 6%. And in some selected patients, they can use a device closure like an Amplatzer plug. Other complications of MI to keep in mind are ventricular aneurysm. That's typical when you have all 3 layers of the myocardium involved. You get dilatation oftentimes at the left ventricular apex. You have a ventricular pseudoaneurysm where you have loss of those layers of the myocardium and it's only held by maybe scant myocardium, but predominantly pericardial tissue and inflammatory cells containing that ventricular rupture, forming this pseudoaneurysm. That's usually in the inferior or posterolateral wall of the left ventricle. Myocardial rupture, not very common. I've seen a few. Typically ruptures into pericardium. These patients are going to go into acute cardiac tamponade. And rupture of the chordae tendineae lead to a flail mitral valve and acute MI. Also not very common, at least from an imaging standpoint, for what we will see. Here's a companion case. This is another ischemic VSD. This one is at the basal septum. You see the thinning of that septum and the defect. This patient also had a pseudoaneurysm of that posterolateral and inferior wall of the left ventricle. Any questions regarding that case? Or comments? Complaints?
Have you seen device closure of the VSDs?
Yeah, I've seen at least one, but I don't think the patient survived long after repair. Most of what I've seen have been just patch repair with pericardium or Gore-Tex. And truly, we had a case recently. I haven't followed up with that case to see how they operated on him. But most of those patients have done poorly regardless.
Yes.
Yeah.
It just,
Um,
I think they need from us the measurements of the orifice, but that's it to know if it's a device versus surgical approach, or do we
yeah,
have to give them any other?
if they can try with a device, as long as the margins of this defect are just uh, good for a device closure, um, they might try with a device, but uh, in my institution, they'll probably just stay with surgery.
Yes, I'm curious how the device will be in latching enough because of the surrounding friable tissue from the infarction. I'm
Yeah.
curious to see one. Yes.
That's what I
Uh,
was gonna say too, Shaiba, where I was fooled one time on this because they wanted the measurements on the CT, but I didn't caveat. I was like, just so you know, there could be a thin like a thin amount of fibrosis here that I'm not seeing. Then they get the MR and the actual VSD was small, and there's like a band of very thin fibrous tissue. So I was gonna ask, how do you guys measure the defect?
um, that's a good question. I don't know. It depends on the type of the defect. The first
Yeah.
one I showed, it's like a weird channel where you have like a almost like a flap of that.
Yeah.
Right.
Yeah,
So
yeah, that's what I had. Yeah, yeah.
so you can measure the defect where the channel ends, but everything else is going to be pretty friable and thin
Yeah,
tissue. So that's not going to hold a device for sure.
yeah.
Yeah. It would have to be a more well-formed defect with thicker walls, really, uh,
Mhm.
to support a device, in my opinion. Yeah. All right. Next up, 57-year-old man with heart failure. So I'm showing here multiple slices through the pulmonary artery and aorta. And there's one big finding here. Adjacent to the pulmonary artery, you see this uh, just series of jumbled vessels, dilated, tortuous vessels. Um, One you can see is extending to the region of the RCA. I don't know if I have another image coming up or not. Here you have an aneurysmal portion of this weird looking vessel. And as they approach the wall of the pulmonary artery, here you can see that there's no um, wall of the pulmonary artery here. So this is communicating here with the PA. Here's a nice render image where you can see all these vessels adjacent to the pulmonary artery, and you can see how one of them is communicating from the RCA and also reaching the region of the LAD as well. So what's going on here? How many people do we have connected? Several. Does anyone want to, any adventurous person
This
want to say?
coronary fistula to the PA.
Yeah. So this is it's a very straightforward case of coronary fistula, and it's a fairly common finding, and oftentimes just like this in this region. So this is a coronary fistula. Basically, you have, and I'll go on in detail in a second, but basically you have a coronary artery that's dumping into a chamber that is, and not draining into, not going into its normal capillary network, right? So you have the coronary artery draining, in this case, into the pulmonary artery. Uh, and This type of fistula in this region is in a region where you actually find a collateral network of vessels that lives there. That's called the ring of Vuissance. And it's basically a collateral network of tiny vessels that may become open or recruited in the setting, for instance, of coronary stenosis. In this case, it's you can see this whole network because you have a fistulous communication with the pulmonary artery. So you have high flow through that fistula. So here's a angiogram showing exactly those dilated and tortuous vessels there. And you can see there's a little bit of blush of contrast in the pulmonary artery here. So coronary fistulas, most common will communicate the right coronary artery with the RV, according to the literature. That's called a coronary cameral fistula, but may communicate with the SVC, atrium, with the coronary sinus, or the pulmonary artery. In my experience, the most that I've seen have been communicating with the pulmonary artery and with the SVC actually, and I haven't seen that many with the RV, with the RV itself. Um, Most of those patients are going to have small fistulas and are going to be asymptomatic. When the fistulas are big or the patient develops symptoms, those are going to be pretty nonspecific symptoms, dyspnea, fatigue, or angina. And the complications are going to be, they're listed here: steal phenomenon, pulmonary hypertension, thrombosis of that fistula, or thrombosis into the pulmonary artery, for instance. In this case, that can lead to embolism. Um, Here's what the literature says. Most commonly from the RCA. You can also have fistulas from the left coronary artery or both. Less than 10% will have from both systems. And most commonly to, at least the literature says that most commonly to the RV, RA, and then PA. As I said, in my experience, and I've seen dozens and dozens of fistulas, most common to the PA and SVC. Here's a massive coronary fistula. I've shown this case in many lectures. Massive coronary fistula draining from the circumflex. So this is a circumflex coronary artery draining into the coronary sinus, and this is a very, very dilated coronary sinus. And that's all I have. I do want to remind you guys that NASCI 2026 is happening in my town, my city of Denver, at the Westin downtown. In September, the call for topics just ended, so you might have missed it. But what's coming up next in the spring will be the call for abstracts, educational exhibits, and scientific exhibits, call for grant proposals as well. There's a couple of grants at NASCI awards as well. So if you have interesting cases and you want to build an educational exhibit, or if you're working on any scientific project and you want to send it as an abstract, please do. As a reminder, that call will come in the spring for the meeting that will happen in the fall. September usually has beautiful weather here in Denver, so it should be a pretty cool meeting. Anybody has any questions, comments?
Thank you very much for.
No, that was awesome. Thank you.
Thank you, Daniel. Really good cases.
Thank you, Dr.
Oh.
Vargas.
Anytime. Jonathan, anything else you want to comment? No?
No, just remember to tune in
What?
every month there.
Yeah, when's the next one? Is there a date for that one?
The next
March?
one will be March 4th, I believe. Yeah.
Great.
And if anyone is interested in volunteering to host the Curious Cases, please reach out to myself, Shaima, Kirsten, Danielle. We are always looking to have great hosts.
Yes.
And we
Awesome.
couldn't do it without you guys. We really appreciate it.
Absolutely.
All right, guys.
Have a good day.
Yeah, have a good week.